And good day, everyone. Welcome to today's national webinar presented by SAMHSA's GAIN Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Today's webinar is titled Barriers and Facilitators of Jail-Based Medication-Assisted Treatment Programs, Setting Up for Success. And the presenters today are Steve Fishbein, Dr. Noah Krawczyk, and Sharon Bean, and I will be introducing them in just a couple of minutes. SAMHSA would like to welcome everyone to today's webinar on this very important topic of providing medications for opioid use disorders in jail settings, both to support treatment and continuity of care among people with substance use disorders during incarceration and throughout their reentry back into the community. Many jails face challenges to providing medication-assisted treatment, what we also refer to as MAT, to a rapidly revolving population in a manner that is quick, safe, and effective. The statewide expansion of MAT across jails in New Jersey has provided an opportunity for the field to learn more about the barriers and the opportunities that jails may navigate in offering MAT. This webinar features information about New Jersey's statewide jail-based MAT initiative, led by Steve Fishbein and the New Jersey Division of Mental Health and Addiction Services. We will also hear about the research of Dr. Noah Krawczyk and her team, which studied the barriers and facilitators of the initiative. And Sharon Bean from Camden County Jail, one of the study participants, will present on the strategies they developed to provide MAT and better set up individuals leaving their jail for success in treatment delivery and also retention. SAMHSA is very pleased to support these three presentations that look at the provision of MAT in jail settings from three different perspectives: state leadership, research, and jail leadership. So thank you all for taking the time to participate and learn from today's webinar. Next slide, please. My name is Erica Ihara. I'm a project associate at SAMHSA's GAIN Center and Policy Research Associates, and I have just a couple of housekeeping items to review before we get started. First, our disclaimer. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters or relating to the technology, please use the Q&A pod at the bottom of your screen to enter your questions. And at the conclusion of the presentations, we will address as many of your questions as time permits. We will also be conducting a couple of polls throughout today's event, and we really appreciate hearing from you in these polls. So if you see one pop up on your screen and if you'd like to enter your information, we do appreciate hearing from you. And you should be seeing one come up just now. Today's webinar is being recorded and the slides will be disseminated via the listserv from GAINS following the event. And we will also notify you when the recording is posted to SAMHSA's YouTube channel via our listserv. A certificate of attendance will be available for download at the end of today's webinar. And just a reminder for everyone that this certificate is for your personal portfolio use only, and we are not able to offer CEU credits for today. We have two American Sign Language interpreters today, Dave Gratzer and Kip Opperman. And so you'll see them, you should see them on your screen. If you don't see them, please use the pin function to make sure that you can see them as they're working to translate today's event. And we also have live captioning today. And to view live captioning, click Live Transcript CC and then select Show Subtitles. So just a quick look at today's agenda. We will hear three presentations, and then we have some time reserved at the end for Q&A from the audience. So now it is my pleasure to introduce our three speakers. Steve Fishbein is Deputy Assistant Director for the Office of Treatment and Recovery Support, Division of Mental Health and Addiction Services in New Jersey. He oversees the division's mental health acute care system and criminal justice programs, which includes numerous projects and services, including the Jail MAT initiative for New Jersey's 20 jails. Next slide, please. Dr. Noah Krawczyk is assistant professor in the Department of Population Health at NYU School of Medicine and a member of the Center for Opioid Epidemiology and Policy. She collaborates with a number of health organizations, public health and government agencies, and her research focuses on addressing barriers to evidence-based treatment for opioid use disorders, particularly among vulnerable groups, such as people with criminal justice involvement. Next slide. And Sharon Bean is Jail Population Manager for the Camden County, New Jersey Department of Corrections. She works with a number of local criminal justice system and community-based stakeholders to safely reduce the adult jail population. And she oversees the development of a continuum of re-entry policies, practices, and programs, including the Comprehensive Medication for Opioid Use Disorder program in the Camden County Correctional Facility since 2018. And I'd like to just take a couple of minutes to take a look at the poll results. So if we could just get that up on the screen and take a look at who's here today in the audience. Thank you to everyone who replied. So it looks like most of you today are joining us from urban areas, about 44%, and with the rest of you split about evenly between rural and suburban areas. We have representation from a number of professional areas. So we have folks in corrections, probation and parole, community-based providers, government, public health, hospitals, crisis services, academia, law enforcement, the judiciary, and a couple of you who said you're in other groups. So thank you so much to everyone who responded. And I am going to turn it over now to Steve Fishbein to begin the presentations. Thank you.
Good afternoon, everybody. It's a pleasure to be on the webinar, having been involved with the GAIN Center for many years, believe it or not. So I'll be talking about our New Jersey jail medication assisted treatment initiative, which I'll just name as JMAT. It is an initiative of the Department of Human Services, Division of Mental Health and Addiction Services in New Jersey, and began in June of 2019 with assistance from our Department of Health and our Department of Correction. So New Jersey's jails are dealing with two populations. I want to point that out because of the kinds of medications that are used as a result of that. The two populations came as the Criminal Justice Reform Act was signed in June of 16. And what that did is make for speedy trial and also for bail reform. So as a result of that criminal justice reform, a majority of those detained in jail are released within 12 to 48 hours of post-jail booking, about 76%. And that's the result of a risk assessment done by a judiciary pretrial unit, which then a judge takes a look at and makes it 6 days a week and makes the determination of release or to continue the person in jail. So our typical population from years ago, which was there for a period of time, is no longer the case. So funding, because everybody is always interested in funding. The jail resources are both state and federal, and are used to assist 20 jails to establish the new program that we have, which now is several years old. 4 jails are receiving federal state opioid response dollars, SOAR for short, and that funding is right now going to the 29th of this month with an extension expected shortly to put us through 9/29/23. And out of a total of $7.9 million for this whole initiative, That SOAR dollars, or those SOAR dollars, are 2.5 million. 16 jails are receiving state opioid funds through the end of this fiscal year, 6/30/23, and that's to the tune of $5.3 million for a total of about $7.9 million going into this initiative. JMAT looks to assist individuals with OUD who are going out on pretrial release in particular. In jail, they get an assessment, medication if the time permits, some kind of therapy or support, and other resources. Post-release, there is hopefully a handoff or a warm handoff to community programs, typically opioid treatment programs or other office-based MOUD programs, other kinds of substance use disorder program, and post-release support. I think it's important to understand that typically jails have not been as involved in treatment of their inmates in general in my way too many decades of service here in New Jersey. But the jails were amenable to JMAP because of the significant influence of people to their jails with an OUD. And I think they all realized that something needed to be done to assist these individuals. One of the other things that I think made for a little more friendly environment with the jails is that we as a state agency offered contract individuality and flexibility. And I will tell you that most jails are not used to doing individual contracts. In New Jersey, a majority of the jails do have a medical service provider who is under contract with the county, but this was new for many. I have to lift up the New Jersey County Jail Wardens Association because frankly, without them lending credibility and assistance in the entire effort, we would not be where we are today. Myself as a liaison participates in the monthly warden meetings, and communication with jail leadership is promoted and takes place frequently. I can pick up the phone, make a call to a warden. Very often we'll get them on the phone immediately and or send an email and have that also responded to immediately, which is just fabulous. So in terms of implementation, we contract with each jail. And frankly, the contracting process was unfamiliar to those jails. I have to say that most jails have been diligent and responsive in the providing of necessary documentation to be able to move the process along and respond positively to outreach effort. There are about 5 documents that need to be processed not only by the jail, but by the county leadership before the money can flow. And it was a bit of a confusing process for many because many of the jails do not have their own business office and have to rely on the counties. Jail reentry coordinators or primary contact staff have been approachable regarding any of our questions as the state regarding revised budgets and submitting the monthly contract monitoring reports or MCMRs, which I'll talk about a little bit later. Medicaid as well has been a responsive partner, particularly in the beginning when we began the whole initiative. Monthly monitoring of contracts for fiscal and performance compliance is carried out by our staff, our DMHAS staff. Each jail is required to submit an MCMR as well as quarterly fiscal reports. Those are important. Sometimes we have to remind the jails to do that. The MCMRs are done monthly, and that is to monitor our contracts, but also for data collection, as you'll see shortly. Training for correctional officers was accomplished by Rutgers University, who had also done similar training, for our Department of Corrections. And they did this training for the jails under contract with Pew Charitable Trust. Training and consultation for medical staff will be conducted by the Centers of Excellence at Rowan University and Rutgers University shortly. So some of our outcomes, and I'm going to show these in some graphics as well. We might as well jump right to the point of what we're trying to do. Since implementation in December of 2019, we basically from June to December of 2019 had individual conversations with every warden, any of their staff about what did they want to do, how did they want to spend the money that was allocated to them, and working on the contract. So from that point to now, here, a second. 69% of eligible people in the jail accepted MAT. And that number is currently about 10,000 inmates. I don't know about any of you in the audience, but for me and for our state, the fact that there are that many individuals who were eligible, and then 60% of those detainees actually being on an MAT is a huge number. About 60% of individuals released on an MAT had a warm handoff to either community OTPs or opioid treatment programs or other MAT providers, whether that's an office-based provider, a doctor's office, or one of our other substance abuse programs who is authorized to provide buprenorphine, for example. 21% of those released on an MAT were assigned a peer specialist as they were going out for the community. 38% were assigned a case manager. Let me stop there for a moment and indicate that some jails had part of their budgets invested in these resources, that is a peer specialist, case manager, or case manager. Other jails focused more on the purchase of medications, of having staff inside who could either prescribe or support the delivery of medication. Each jail was slightly different based on their unique environment. About a third of individuals on MAT as they were released, so there were, since the very beginning of this program, about 5,700 individuals, detainees who were released on an MAT. So 32% of those individuals entered dependent, halfway house or other kinds of dependent or independent living, with 8% of those individuals being released to a DLC facility. Here's some data on our FY20 and FY21. As you can see, these are large numbers, of course, because we have all the jails. But if you look for FY20 and 21, we have about 6,200 individuals who accepted, that's inmates who accepted an MAT. Out of that number, about 1,000 individuals were on methadone. Many of those individuals came in and were continued on methadone, or there was a pregnant female who came in, it was placed on methadone. None of the jail providers at this point can prescribe methadone themselves. About 4,300 between FY20 and 21 were placed on buprenorphine. This is in particular important because many, as I indicated earlier, of the inmates were being released within 12 to 48 hours, and some of the longer-acting other medications like Vivitrol or naltrexone are not indicated without some abstinence from an opioid being in the system, which if you're being released in 12 hours or even 48 hours, is not going to be guaranteed. So many folks were placed, many inmates were placed on buprenorphine. Let's see. So you can see some of the distribution, small amount on naltrexone, a small amount on Vivitrol. Many of our jails do not depend on that. Other jails around the country, from what I've read, do. So the total inmates on MAT over those two fiscal years were almost 6,000, and about 3,100 were released on an MAT at the time of the handoff. And you can see the rest of that. Let me show this in a little bit of a different format. I will, by the way, the slide is a little out of order. I'm going to go over what some of the medications are real quick. For those of you who may not be knowledgeable about that, not everybody is. Once the person's determined, they're offered and given an option to accept treatment. Some folks may be having an OUD as identified at their initial screen by a nurse coming into the facility. As you can see, many more individuals had an OUD and were eligible to receive a MAT, while the number dropped off for those offered and then dropped off further to be accepted. Again, when you consider where we as a state were 3, 4, 5 years ago, this is a tremendous increase in the numbers. And anytime I look at those numbers, I'm astonished. So the medications that I've indicated before, and you can see in the pie chart what the distribution is: methadone, a synthetic analgesic drug similar to morphine in its effects, but longer lasting, used as a substitute drug in the treatment of morphine and heroin addiction. And again, I'm just going over this in case some of you are not familiar. Buprenorphine is a class of medications called opioid partial agonists or antagonists, and naloxone is a class of medication called opioid antagonists. Buprenorphine alone and in the combination of buprenorphine and naloxone work to prevent withdrawal symptoms when someone stops taking opioid drugs by producing similar effects to these drugs. I think there's an advantage and I think the jails have realized that in prescribing buprenorphine, because frankly, when someone is beginning withdrawal, even within the 48 hours, that makes for some potential behavior issues to come up and management becomes more difficult. Sublocade would be an extended release injection, subcutaneous, which would last for a while. Few of the jails at this point, but my colleague from Camden, Sharon Bean, may be talking about that because Camden has started to use it. Naltrexone is an extended release injection medication, which is given once a month and blocks the high from the opioid. So hopefully taking away the incentive to actually take the drug. However, it can have serious side effects, both that and Vivitrol, which is another form of the extended release medication, because it doesn't stop somebody from taking the opioid, and that may result in a withdrawal cascade. Some more data from our MCMRs. These are some data on what happened as the person is being released. So unfortunately, we do have a small number of folks who are released to homelessness, because once the judge has ordered the release, there's no way to hold them and get them into some program if it's possible. New Jersey, like I'm sure other states, has a tremendous pressure on housing. Some number are released to a homeless shelter, transferred to the Department of Corrections. As I mentioned, some are released to independent living, meaning they've got their own apartment or they're living with family. Some are released to dependent living, which may be halfway houses, residential programs, etc. And you could just see what this looks like in terms of the handoffs out of the numbers released. So that is pretty much my presentation. I would like to now hand it off to Dr. Noah.
Great, thanks, Steve. Hi everyone. My name is Noah Kravchik. I'm an assistant professor at NYU School of Medicine. And today I'll be talking about a research study that we conducted along with our colleagues at Johns Hopkins and Pew Charitable Trust to look at barriers and facilitators to implementing this medication treatment initiative that Steve introduced just now. So just to give an overview of what I'll be covering in this section, first I'd like to kind of bring us back to some background on medications for opioid use disorder in the criminal legal system, just to really give some context into why this case study of New Jersey is so interesting and important. I'll then dive into the specific study that we conducted in New Jersey and specifically summarize some findings from qualitative interviews that we conducted with staff across these New Jersey jails, specifically around barriers and facilitators that they were experiencing in this effort to implement medication treatment. So in the way of just some background, and I know a lot of folks on this call are very familiar with this, but really just to emphasize that substance use and overdose is highly prevalent among individuals who are involved in the criminal legal system. We know that really decades of criminalization of substance use as well as addiction have made our legal system really the largest provider of addiction care in the country, as well as mental health care. From the latest estimates that we have, we know that around 60% of incarcerated individuals across the country have a substance use disorder, and at least a quarter report histories of opioid use. We think those numbers are actually much higher, especially since a lot has changed over the last 2 decades and these data are pretty outdated. And unfortunately, we also know that overdose risk as a result is extremely high upon release from incarceration. Just to give an example from a classic study from Ingrid Binswanger in 2007, was really one of the first studies to show that really relative to overdose death in the general population, individuals who are leaving jails and prisons in the first couple of weeks are something like 100 times higher, have greater risk of death in those weeks post-release from incarceration. And while this is an older study, we've really seen dozens of other studies that have shown similar findings. And unfortunately, we know that this problem has just gotten worse with today's fentanyl crisis and the lethality of the opioid drug supply. And as Steve talked about, we know we have these medications for opioid use disorder, also referred to as medication-assisted treatment. I'll just mention the transition to really using the term medications for opioid use disorders, because we know it's not that these medications assist treatment, they are actually the main treatment for opioid use disorder. And that's why I refer to them as MOUD throughout my talk. And I won't go into this. You heard about methadone, buprenorphine, and extended release naltrexone or Vivitrol as the FDA approved medications for opioid use disorder. And I'll just re-emphasize that what we know about these medications, and specifically buprenorphine and methadone, the opioid agonists medications, is that they are extremely effective at preventing overdose risk. So on the right, I show a survival curve from a study that we conducted in the state of Maryland, just as one example that's been replicated in many other places, where you see the blue line is time to overdose death among people who are in treatment for opioid use disorder that does not involve medication. And in red is individuals who are in treatment that involve buprenorphine or methadone. And as you'll see here in this curve, medications reduced overdose risk by over 50%. Compared to treatments that do not involve medication. So we really want individuals who engage in care to receive these treatments. And of course, as we know, unfortunately, a minority of jails and prisons actually offer any medications. This is a map that shows the prevalence of jails and prisons that provide these 3 approved medications. Some has changed since a few years ago when this map was conducted, but we know that there's still a lot of gaps in access to these treatments. And unfortunately, we also know that the criminal legal system rarely refers to individuals to medication treatment upon release from incarceration. So just as an example, a few years back, we conducted a study that found that only 1 in 20 justice-referred adults receiving opioid use disorder treatment actually received any medications, such as methadone or buprenorphine. And why have we seen these gaps? So of course, there's been a high historical stigma against these medications, with this false notion that medications are replacing one addiction for another. And I think also from a logistical perspective, there really has been lack of resources, infrastructure, and training and addiction for staff, as well as providers that are working in these settings. And particularly in jails, the reason this is so interesting is because, as you all know, they're not centralized. They're often revolving doors where people stay incarcerated for unpredictable periods of time, which really does complicate the process of coordinating these treatments, especially when historically they have not been part of standard of care. So to get back to what all of this means for New Jersey, as Steve discussed, in 2019, New Jersey enacted the statewide effort to expand medications through incentivizing via financial support as well as technical assistance to jails to help expand their existing programs or start new programs for medication treatment, both behind bars as well as helping people link to community treatment upon release. And I won't go into this, but really important, of course, is this context of bail reform in New Jersey that meant that less people were being incarcerated, and they were also being incarcerated for shorter periods of time, which was important for really thinking of implementation challenges in this context. So what was our role? So as researchers, we really wanted to understand what were the barriers and facilitators that those that were implementing these treatments across jails were experiencing. And this was for kind of a twofold purpose. First, it was to inform technical assistance efforts, so to really understand what the state could do to help coordinate this initiative, as well as our technical assistance partners, which was Pew Charitable Trust, to help jails really improve their infrastructure and capacity to provide these medications, but also for a purpose like today to really inform other states and jurisdictions that are interested in expanding treatments to their local jails in a similar respect. So just very briefly to talk about what we did as our study design, we recruited 11 of the jails that participated in this medication treatment expansion program, and we conducted in-depth qualitative interviews. Specifically at each jail, we spoke with usually the warden of the jail or some other kind of director, as well as individuals who are working within the medical and social services leadership. So for example, that could be the medical director of the jail or a re-entry coordinator if that position existed for a particular jail that we spoke to. And these interviews lasted about an hour, and we transcribed and qualitatively coded them specifically around some themes that we were interested in exploring. So particularly our questions in these interviews really focused around 3 topics. The first was just trying to understand what the current capacity and practices were for delivering medication treatment kind of throughout this implementation process. We asked about what primary challenges were being experienced around delivering medications for opioid use disorder. And we specifically wanted to understand what was going on in the context of bail reform, as well as COVID, which did, of course, as everybody knows, become a very big challenge for jails and other correctional settings throughout this period. And finally, we really wanted to learn what strategies have facilitated implementation of these services as well. And I'll try to cover this very quickly, but we essentially identified 6 recurring themes in our interviews. So the first theme that we learned about was that capacity and practices for delivering medications for opioid use disorder really varied across jails. And one thing that we noticed was that practices that were discussed often were not based necessarily in latest clinical guidance around delivery of opioid use disorder treatment. So just to give some quotes as examples of what we learned, one participant said in the interview, when they come in, they will go to a 5-day detoxification program. And the reason for that is to preserve the opportunity to start them on extended release naltrexone. Nothing prohibits us from starting them on one of the opioid full or partial agonists, but we do detox everybody to abstinence and then start the process at approximately day 5. So this is an example of a jail that was requiring everybody to go through detoxification before starting these medications, which we know is not a necessary practice to begin people on these medication treatments. Another participant we heard from said, MAT itself is, as a singular act, is a pointless gesture without the talk therapy to go along with it. And we know from a lot of evidence that actually these medications are highly effective whether or not they're accompanied by behavioral treatment. So we did see kind of some discrepancies between the latest clinical knowledge of these treatments and what was being implemented among individuals that were running these programs in the jails. The second theme that we identified was that limited resources and the highly regulated operations that occur in jails often challenge delivery of medications for opioid use disorder behind bars. So we heard that providing medications was viewed as really time and resource intensive, and this was despite limited funding to support these treatments. So one participant said, "Right now, I have about close to 40 patients on Suboxone alone. To transfer all 40 patients to us in the clinic to give them Suboxone, and the timing for the nurses and the custody staff, it takes us almost about 3 hours to medicate these patients." Another participant said, "I think on the table, we all know that what the elephant in the room is. It's funding. That's the biggest challenge. If we had the funding, we could certainly expand our program." So this was interesting to hear that despite the funding that was coming from the state, there really it was felt that there was limited bandwidth in terms of the resources to actually deliver these medications. Another thing we heard about was that these short jail stays left a very short window to actually provide these medications, and this often presented a challenge. So one participant, just as an example, said, "We don't intend to start Suboxone here because of number one, time constraints, and number two, time constraints. I mean, the average stay will probably be 3 days. It's because they come in and out, which is different from the prison system." Another participant said, "They're in and out before we can safely manage their withdrawing from polysubstance use and getting them initiated on a program that would involve pharmacological interventions." So again, a lot of concerns around this short period of time to actually start people on medications before they leave jail. A fourth theme that we heard was that limited availability of community-based providers in the area often limited linkage to care at reentry, which was part of this initiative. So we heard that lack of existing partnerships or knowledge of community MOUD providers often caused reluctance to even deliver medications while people were still in jail. So an example, one provider said, "Let's say if they get discharged after 4 or 5 days, there's really no place for them to go because of the availability of resources outside. Because I cannot just call any physician there and say, 'Can you take care of this patient?' That won't probably work up here." Another participant said, "The doctor's only concern is to ensure that they're obviously already linked up with a provider on the outside. Otherwise, he would be uncomfortable with allowing them to leave with a prescription." So even in cases where there was capacity to provide medications while people were in jail, there was really a concern about doing so when they didn't have a good system of linking people when people were leaving jail. A fifth theme, in which I wish I had more time to talk about, but you will hear about the Camden experience, which is really an excellent example of this, is that there was also many facilitators and creative solutions that jails discussed of how they did deliver these medications for opioid use disorder despite multiple challenges that were being encountered. So just to give very brief examples, one thing that we heard a lot was actually about trying to speed up this MOUD intake process because of these short jail stays. So one jail said, "We typically can start medications very, very quickly. We don't really have a good grasp of how long any specific person is going to remain here. So we start medication as soon as they're clinically qualified. We don't use jail times, transfer dates, time close to release as prerequisites for treatment." Another example of a strategy that was used is that some jails provided bridge buprenorphine prescriptions at jail release to really allow people to have some time before entering treatment in the community because of that very risky transition period between jail and reentry. So one provider from a jail described, "Upon discharge, we first send over a prescription to the pharmacy for up to 3 days, and they pick up the medication, buprenorphine, for up to 3 days. And that will give them enough time to make appointments to go and see the outside provider." Lastly, we heard that despite a lot of concerns around buprenorphine diversion within the jail, that some jails were addressing this using education and understanding. So as one participant explained, "One thing we do when somebody does or there's an incident of diversion, We try and just work with the individual to see how we can best help them make a different decision in the future. We're always looking for solutions to that problem, and a solution is not removing someone from the program. Education, education, and re-education seems to work. Lastly, I just wanted to touch upon COVID, which of course brought new challenges, but also many opportunities. So while we heard that COVID, of course, slowed expansion of medication treatment as this was all occurring during the same time, it also led to some innovation specifically around the use of telehealth. So one participant mentioned, we were a couple of weeks away in March when we had our plan in place. COVID hit and we actually backed off from implementing the distribution and administration of Suboxone. However, we also heard from another jail that said that they had a local organization offer telehealth Suboxone or buprenorphine initiation and dosing until people could get their own community provider. So interestingly, there was some use of these new COVID-19 flexibilities around initiation of buprenorphine via telehealth to actually get people linked with providers on the outside of jails even before they were released. So what are some takeaway points from our research? First, we found that use of non-evidence-based clinical practices really suggested the need for jails to follow standardized and regularly updated guidelines on medications for opioid use disorder derived from clinical experts on the topic. We also learned, of course, that consistent allocation of resources was critical to sustaining medication management. And although I didn't talk about it, as we saw from Steve's talk, the importance of effective data collection and reporting for understanding the implementation and success of these programs. And you'll hear more about this in the Camden experience as well. Third, we learned that efforts to increase jail-based medications must, of course, be paired with efforts to increase availability of medications for opioid use disorder in the community, but also to create sustainable jail community provider partnerships to allow people to be transitioned safely into care upon released into the community. We heard, of course, that short jail stays require efficient medication intake processes and these ready partnerships to facilitate even when someone is in jail for a very short period of time, to make sure that even taking advantage of that time can be a good opportunity to connect folks with providers on the outside. And finally, we really did hear that jails are creatively addressing challenges through new programs, partnerships, strategies, and they can really act as a resource to one another via shared forums, which is just a great example of today's session. So our jails and areas can learn from this experience as well. So with that, I'll just thank, of course, my many, many collaborators. These are my co-authors on this project and collaborators from Johns Hopkins, as well as the Pew Charitable Trust that were highly involved in this project. Of course, the New Jersey Division of Mental Health and Addiction Services, the County Jail Wardens Association, and the New Jersey Centers of Excellence that were really the leaders of this initiative. And finally, this work was funded by a grant from Bloomberg Philanthropies. And with that, I will transfer it to Sharon to talk about Camden. Thank you.
Good afternoon, and thank you all for being here today for this important webinar. I can see just by the number of participants and the activeness in the chat that this is really an important topic that's not just important to us, but to everybody and our colleagues across the country. My goal for this session today is to learn how Camden County went from no MAT to providing all 4 in less than 3 years, and how we're able to do it, to convey the challenges with implementing a MAT program in a correctional setting and strategies that helped us overcome these challenges and barriers, share concrete strategies and solutions integral to an effective MAT program, especially the value of fostering relationships, and to realize the importance of knowing whether your program is successful. But before I dive in, I just want to give some background of Camden County, New Jersey. Camden County has a population a little over 500,000 with a median income of 67,000. Our county seat is Camden City with a population of 77,000 and a median income of 26,000. And where almost 37% of individuals live below the poverty line. Bookings from Camden City account for approximately 50% of all of our bookings at the Camden County Jail. And in 2001, the total number of bookings in our jail was almost 6,300, and our average daily population was 876. Additionally, much like the rest of the country, Camden County continues to experience an opioid epidemic, with overdose fatalities substantially increased consistently between 2017 and 2019, with a decrease occurring in 2020. Camden County continues to account for a large percentage of heroin deaths in New Jersey. And while I don't have 2021 numbers up here, we do know that while overdose deaths continue to decrease, we are seeing an increase in the number of overdoses in general. But on to what you really want to hear about, and that's MAT. Warden Towers wasn't able to join us today, so I will just make this mention. If she was here, she would say it. Our MAT program really started based upon her philosophy that if we are not denying individuals medication for heart situations or for diabetes or for any other medical need, that we should also therefore not be denying individuals medication for opioid use disorder. And it was with that we really were able to take this first step, and that was with providing Vivitrol beginning in June 2018 in our facility, and in February 2019 expanded to include both buprenorphine and methadone, and most recently in February 2021 we added Sublocade. All forms of MAT are continued if received in the community, and we will initiate for all forms except methadone unless you are a pregnant female. On average, 20% of our jail population, which is on any given day 213 individuals, receive MAT in the facility, and that's current year-to-date 2022. The MAT program in Camden County has evolved over time and in phases. I can tell you, if we waited until we had everything in place, we wouldn't have even gotten as far as Vivitrol. Our first phase entailed addressing and identifying that education and policy development was very much needed, identified MAT champions, both in our facility, among our corrections officers, among our medical staff, and among our community, education for all of our staff. We identified initial program participants and then expanded the participant group as our program expanded. Participant education and group counseling, extended release naltrexone, Vivitrol. We added, began providing Narcan for individuals at the time of release, facility campaign promoting MAT, assigned custody staff to our MAT program. We made changes to our jail management system, which is LMS, and I'll talk a little bit more about that later. We coordinated release times to help better facilitate the connection of individuals upon release to treatment providers in the community. And we established an MAT committee / case conference committee. Phase 2 and phase 3 entailed a deeper dive into more specific policies and logistics as it related to actually implementing and providing dispersing MAT inside the facility, developing community providers for referrals, increasing our education format, increasing our group counseling, again, expanding eligible participants based as we expanded our medication, adding Suboxone and Sublocade, continued maintenance with methadone was part of phase 2. We established partnerships with our various opioid treatment program providers in our community, applied for technical assistance on MAT. We were able to work with BJA and a number of organizations to be able to get guidance on how best to do an MAT, have an effective MAT program in our jail. We expanded group counseling to include individual counseling and ensure that we were all collaborating and on the same page as it pertains to building our data capacity. And I'm going to elaborate both on those a little bit later. Our experience over the last 3 years has taught us time and time again that getting the medication is the easiest part of creating an MAT program inside our facility. And like I had said earlier, we have to start somewhere. We could not wait until we had everything in place. And what we learned is the medication was absolutely the easiest part. It's the counseling, it's the support, it's reducing the stigma. And so that was just something that we wanted to be able to lift up and share. In Camden County, we experienced a number of challenges with implementing and providing MAT in our facility. I could spend my entire time talking solely about these challenges and strategies, but I'm just going to highlight those that were most impactful to us. They include responding to and minimizing the stigma associated with MAT, with staff's corrections, with medical, and with our jail population. Ensuring effective communication amongst the key players to ensure all individuals received MAT if appropriate, and importantly, in a timely manner, and offered counseling. Addressing diversion of MAT medication. This seems to be certainly a hot topic as well. Planning for individuals that are released within a moment's notice. Noah had just referred to this with bail reform and criminal justice reform in New Jersey. The number of folks coming in and out within 24, 48, 72 hours certainly has increased, and therefore your time period to get them treated, diagnosed, and connected to a provider then shrinks as well. Our goal is to ensure continuity of care, timely connection to treatment upon release, access to medication between release and follow-up appointment, so as to not withdraw, and especially important for those where we are initiating MAT in our facility. But the good news is, ideally with challenges come solutions. And the strategies that Camden County we've developed and implemented, again, I mean, I could certainly talk forever and not tooting our own horn. There's just more, so in depth, the work that goes into really identifying effective strategies. But to present just a few for all of you today, I wanted to focus on MAT education for incarcerated population and our corrections staff. We invested in this education for everybody, including our community partners. We contracted with a community provider to facilitate MAT education sessions that were specifically tailored to each audience. We recognize that the message for our medical team is not the same message for our jail population and our corrections officer. It's not the same message for our community providers and our partners and our commissioners and our county leadership. So ensuring that those trainings and the messages were in fact geared and tailored to our audience. And we also incorporated MAT education and training into the Department of Corrections annual training program as well, and building it into new officer training. So it doesn't seem sort of like in addition on site. This is very much now embedded into our correctional facility. We implemented weekly case conferences with all system partners. Now those case conferences are held twice a month. To create a space to troubleshoot any and all barriers and issues regarding MAT in the facility. It is in these case conferences that diversion, issues with timely access to medication, issues with prescriptions post-release, issues with coordinating transport to our methadone clinic provider in the community, where all of these issues are lifted up and we're able to create a forum to troubleshoot, well, what is happening? Why are we having these issues? And how can we make those changes? As well as discuss the logistics of the program, dosing hours, dosing locations that may or may not be working in the facility. We may develop a policy that works for corrections, but once implemented, we see that it's not only does it not work for our medical team, it throws their entire schedule into chaos. So creating a space where we can have those regular conversations. And it's because of these meetings that we aren't waiting 1 month, 6 months down the road to know that there is a problem. We're able to pretty quickly identify it and to pivot and make any course corrections that are necessary. And then not long after adding Suboxone into the MAT program, the facility was plagued with medication diversion challenges. In response, we created a new policy to minimize diversion. In Camden County, our policy is to just be succinct about it. If you divert 3 times or more, you continue to meet with our substance use counselor inside the facility, and following that, you are either tapered off the program or you are transitioned to Sublocade. What I do want to note is individuals diverting Suboxone MAT are afforded the same rights and opportunities as individuals caught diverting any other type of medication in the jail. And this ties into the education. When diversion first came up for us in the facility, the initial sort of response was just take them off. And we're like, well, what do we do with anybody else who's diverting any other type of medication? And we need to be sure we aren't treating them differently. I mean, that's part of ongoing education with our team. Consistent, additionally, with creating some additional strategies with ensuring continuity of care, we created a discharge planning process with admissions, medical team, and our reentry unit. I'm going to expand more on this in a brief moment. And we also worked with the Department of Corrections, worked to reallocate any existing resources to staff the MAT program and our reentry unit to bring our work to fruition, our prior strategies that we've talked about to really begin, to establish what we're setting out to do and achieve our goals. One of the areas why we were able to reallocate these positions is that we did see a reduction in our jail population prior to criminal justice reform, but then also since criminal justice reform, that our jail pop continued to go down, which freed up officers and which enabled us to have conversations with the warden and the director about what can we move them around and actually really dedicate and commit staff to this unit. We've also added Medicaid presumptive eligibility screening as a strategy. One of the challenges with ensuring individuals get their medication, not only the bridge meds, but are able to continue the medication after the bridge meds. Our partner, Cooper University Healthcare, screen all of our MAT patients for healthcare and for presumptive eligibility if they do not have health insurance at the time of booking. In addition, we are constantly revising our bridge med policy. We began with only providing a 3-day script. We then expanded to a 7-day script, a 14-day script, and when possible, individuals leave with a 30-day supply of medication. When we know the release date of an individual, we are able to order the medication in advance, eliminating all of the issues regarding sending and receiving prescriptions. And lastly, we implemented or instituted a prescription hotline over the last 2 years, where any individual, not just our MAT clients, but when leave the jail, are able to reach medical immediately if there are any issues with receiving their medication post-release. A little bit more in our discharge planning process. We put alerts into our vendor management system, OMS, so admissions, reentry, MAT navigators, and medical are made aware of those being released, who is on MAT, and therefore who needs to see the nurse prior to discharge, who needs to have a script sent at the time of release, and where does that script need to be sent, who needs to be connected to a provider for continued treatment, who needs to be given reentry cards with our navigators and prescription hotline information. All this information is now included in backpacks that are given to each individual that receive MAT in the facility at the time of release. This is just a list of some of our providers that we've cultivated relationships with on behalf of those leaving our facility to increase the likelihood that their treatment and medication is continued once they are released. And our goal here is to have an impact on those leaving and not relapsing, overdosing, fatally overdosing, and or being rearrested or reincarcerated. And I will tell you, when we first started this, started providing MAT in our facility 3.5 years ago, there were only 2 providers on this list. So it has grown over time. And that is one of our biggest lessons learned and takeaways, is that our partners are 1000% the backbone of our program, both our partners in the facility and our partners in the community. The Camden County Department of Corrections can administer all the medication it needs to, so that we're effectively treating individuals with an opioid use disorder in our care while they're in our care. But it's the relationships that have truly made our program what it is today. I can't stress that enough. We can't do it alone, and more importantly, we shouldn't be doing it alone. Corrections is one part of the equation. We rely heavily on our community and our stakeholders to help inform and grow our program in a collaborative way. And we do this to not only for the individuals while they're incarcerated, but to ensure stability and longevity and effectiveness over time. I have about 1.5 minutes left, so I'm going to pivot and take that time to talk quickly about data. I know it's not the most popular topic sometimes, but it is an essential component of your program. You want to have a discussion with your team regarding what is the expected impact of providing MAT in your facility. And this will lead you to identify what measures to collect, report, and share. Here is just listed some of the measures that we are collecting here in Camden County. And so why is data so important to our program? It's for so many reasons. Everybody has an opinion. Data does lead us to where the problems exist and where to implement change to try to achieve desired results. Having one data system allows us to avoid the downfalls of capturing and reporting data in multiple systems, depending upon the number of stakeholders at the table. And having accurate collection and reporting of data in a collaborative, accessible manner will lead to informed, meaningful, and sustainable policy and practice changes. And to do so in a way that everybody is on the same page, they have trust and confidence in the data. Are we having an impact? What kind of an impact, positive, negative? Is the program successful? What or who defines successful? And are there any intended consequences as a result of the program and related policy or practices? One of the measures that we're collecting that we hadn't even thought about was the number of attempted suicides in our facility. We hadn't even thought about the fact that by providing MAT in our facility, that we would have that would result in a decrease in the number of attempted suicides in our facility. So that's one of the unintended consequences. They can be good, they can also be bad, but it's important to include that in the conversation. And just these next few slides are just examples of the data that we have been able to collect, both locally, internally with our team, but more broadly, Camden Coalition of Healthcare Providers is in the process of completing our MAT evaluation for those who received MAT through 2020. So stay tuned, that should be finished later this year. But it gives us just another layer of looking at data in a way that's not just how many people are coming in and how long are they staying, but connecting it to our fatal overdose data, how much time lapsed between jail release and a fatal overdose, comparing non-MAT with MAT population. One of our goals is to actually to create healthcare profiles for individuals. So for our MAT populations, again, partnering with the coalition and our health information exchange, looping into the conversation inpatient visits, ED visits, opiate overdoses, so that we can look at this not just from the siloed perspective of MAT, from this one point in time from when they come into our facility, but more broadly, what does this mean for our conversation around opioids, overdoses in our community here in Camden County. And this is just another example. It allows us to look at overdoses that happen for individuals prior to coming into the jail and receiving an MAT, and then overdoses that are occurring at the time of release. And this just leads us to more questions. Of those that overdose following release, how many were successfully connected to a treatment provider? How many were connected to a peer specialist? How many continue treatment? Just a few questions that we use all of this data to not only provide answers, but it always takes us a little bit deeper into the conversation and to identify what's happening so that we can, again, approach this from a more global perspective and not just solely through the lens of the jail. And I know it's my time, I'm going to wrap it up. But a lot of people think data is used just for data's sake. But the fact is, in Camden County and everywhere, I encourage you to use data to actually advocate for change and to inform policy changes. All of the strategies that I've talked about, that I mentioned, we were able to achieve because of the fact that we could reflect this in our data. We know that it's the number of people who aren't receiving scripts and needing or have health insurance and to connect with Cooper. So there is not just the need to capture the data to get more grants and to get funding, but to inform policy changes and also to advocate to your leadership for potentially a reallocation of resources at a higher level. And that is it for me. Thank you.
Thank you, Sharon, and thank you, Dr. Krawczyk and Steve Fishbein, for your really informative presentations today. I'm sure you've all seen there's a ton of activity going on in the chat right now, lots of great comments and questions from the audience. So first of all, for those of you in the audience, if you have questions that you haven't submitted yet, this is the time to do that. If you go to the bottom of your screen and find the Q&A pod, that is where we're asking folks to post your questions, and we'll try to cover as many as possible in the remaining 20 plus minutes that we have for today. I think I'd like to start with Medicaid, because there was a pretty active conversation going on in the chat here about Medicaid, how folks in different areas, different states are approaching that, and some folks are reporting applying for waivers for potential coverage of medications while incarcerated. Steve, I wanted to start with you because I noted that you had already started replying to one of these questions around
Right.
Medicaid, what New Jersey is doing for reinstating medication, for reinstating Medicaid
Right.
upon release. And then I'll open it up to others if there's other information you want to share about what New Jersey is doing around Medicaid coverage.
Okay, thank you.
Thank you.
So Medicaid has partnered with the Administrative Office of the courts and the jails, because the file goes through the courts. And when an individual is incarcerated, that list of individuals are put into a file. That file is transmitted via the courts to Medicaid. Medicaid will then process that file and suspend the person's Medicaid. There really is a lot of concern, other states may do it differently, that somehow Medicaid will be used inside the jails or prison for that matter. And that would really be a significant issue for SAMHSA. And so those, that individual is suspended. However, at the same time, those individuals who are being released from the jails are put on into that same file. So as soon as Medicaid gets that, which is usually overnight, so the next day, they will reinstate that person's Medicaid. There could be a day lag, but if somebody needs a script, the pharmacy can contact Medicaid and Medicaid confirm that that person's Medicaid has been reinstated. So that's an electronic automatic process. And as long as the jails are able to keep those files up to date, because that's a lot of work, people should have their Medicaid reinstated. We have also partnered with Medicaid over the last X number of years to expand the use of presumptive eligibility by all of our substance use providers, as well as our mental health providers, so that an individual coming out of the jail who doesn't have their Medicaid reinstated yet, or who does not have Medicaid at all, the provider they go to can actually do a presumptive eligibility application, which allows that information to go electronically to Medicaid and be confirmed while that person's information is being processed and confirmed, so that the person can get into treatment and that's not avoided. And since many of the individuals who go into into county jails are individuals who would ordinarily be eligible for Medicaid, that should work. We've been able to answer some questions that some of the jails have had, but not that there aren't hits and misses, but generally this seems to work reasonably well.
Thank you. Noah, Sharon, anything you'd like to add before we move on to other questions?
No, I will just add what we do in the Camden County Jail is knowing that there is sometimes a delay, 24 or 48 hours for individuals with Medicaid, where they have an active Medicaid. The jail covers the cost of the bridge meds for buprenorphine for individuals who are released. So anybody who receives a script, that's paid for out of the jail's budget. They don't have to worry about having insurance active at the time. which is in part one of the reasons why we had extended it from 3 days to 7 days to 14 days. And particularly since COVID, the ability of getting connected to a provider in a timely manner was also challenging. So that was, I just want to make that point. And then the one challenge that, Steve, that we run into is individuals could come in and have Medicaid active and it's turned off. Sometimes their Medicaid will become inactive if they've been incarcerated for a period of time. So it's not just as simple as switching off a button or switching back on, rather. So which is why we cover the cost of the bridge meds.
Thank you. A number of questions came in about training of specific staff, and I'll start with peers because we got a couple of questions about that. I know there were a couple of references already in the presentations to people with lived experience being part of the team and facilitating your programming. So one question we received is, what's the policy for integration of recovery certified staff to provide support during transitions? And is this workforce being fully utilized? So I would open that up for anyone who'd like to just respond, maybe provide a little more background on how you're utilizing peers, the people with the lived experience in your programming.
Well, we certainly have an explosion of peers who are being trained. We have an agency that our division funds to provide peer training and have folks get certified as certified peers. Peers are in many of the services that are provided throughout the state. In relation to the jails, I think a lot of that has to do with providers that the jails partner with who have peers that make that connection, as opposed to the jails themselves per se having a peer specialist. I'm not sure if Sharon has any different perspective on that, but we really rely heavily on peers in New Jersey.
Yeah, actually, I mean, we have sort of a fresh update, and I think some of our peers are on this webinar, but we actually use separate grant funding from the Department of Justice, BJA, where we've implemented a peer support teams for individuals returning home from the jail that have not only an opioid use disorder, but a substance use disorder. And our teams are comprised of an individual with lived peer recovery specialist, and then an individual that has the lived criminal justice incarceration, knowing they're not necessarily one and the same. And it has been a transition or a sort of a journey to get clearance for peers who may or may not have a prior criminal history in our jail. But I'm so happy to say that all of our peers have actually been cleared and will begin working in our facility. So with individuals, not just in our MAT program, but individuals with a substance use disorder. And we've been really, pushing, sort of advocating for that shift to happen over the last 3 years. And we have peers that have been cleared.
That's wonderful.
Thank you. And Sharon, we received a question about training of correctional officers. I know you talked a little bit about the trainings that you're using at your site. Is there anything else that you could share more specifically, like about the type of curriculum, length of training, or other information that people are wanting to hear about what that training looks like for correctional officers?
Sure. I mean, I don't want to misspeak, so I can certainly follow this up. I mean, Eric, I can send out what our training module looks like. And I know that it not only includes a thorough review of what our policies are. So what is medicated, what is MOUD, what are the different medications, what the expectation and partnership is of our correction staff. But then there's this whole section on addiction medicine and addictions, the science behind addiction, and to really get individuals to understand that this isn't just somebody who's choosing to use drugs to choose to use drugs, that it's more than that. So I can provide that as a follow-up with what we actually include in our training.
Yeah, and to add on to what Sharon's saying, the training done by Rutgers University for the corrections officer, which is throughout all jails, is being done as a training of trainers. So the training officers or someone who's designated in the jails went to a training of trainers. And then I believe that many will be using some form of teletraining or other, forms to really educate all of the corrections officers. I do not have off the top of my head the range. I think a lot of it is what Sharon's talking about. We certainly can get the list of topics that are being done, but essentially in the same but a little modified training was done for the Department of Corrections, who also uses MAT and has been doing that for a while. So they need their corrections officers trained as well, because we want the COs to be supportive of the individuals on medication, and they're involved in many cases of transporting that person from their units to the medical unit, et cetera. But as Sharon said, I can certainly try to follow up and assume we're getting it to you, Erica, and you can get it out to folks as the way to probably do it.
Sure. Yeah, that would be appreciated if you send it to us at the Gain Center. Thank you. So the next question is, let's start with Noah and Steve, because I think this is more like a statewide, kind of applies to like what you're doing statewide. Question about clinical practice, and like how the current policies and procedures are addressing those who have polysubstance use, so opioids in addition to specifically methamphetamine use. Are there differences in protocols, or just how are you handling that?
Noah, you want to take a stab?
Sure. So, I mean, I think Steve can speak about New Jersey specifically. This is definitely, just to speak a little bit more broadly about this issue, it's definitely something that, of course, there's a lot of concern around. We're not in an opioid crisis per se, we're in a polysubstance use overdose crisis. And we know that there's a lot of other substances that are being used and also being contaminated with fentanyl other than opioids. We do have other treatments for stimulant use, but they are not as straightforward, and really as the evidence isn't as strong as they are with opioid use disorder treatment. So this is a challenge that's not only in correctional facilities, but really we're seeing across the country and in substance use treatment more broadly. So I think it's a really good an important point to be thinking beyond opioids, and something that needs to be not only developed in terms of the science itself, but also from what we do know. So for example, contingency management is the behavioral treatment that is most evidence-based and effective with treating stimulant use disorders. It's often not available in a lot of behavioral treatment. So really thinking about how to bring those evidence-based interventions into these settings as well, I think is really a kind of on the cusp of a challenge that many of these facilities are probably thinking about. And I'll let Stephen and maybe share.
Yeah, we hopefully very shortly will have MOUs signed with Rutgers and Rowan universities, who have centers of excellence for these medications. And I know we're well aware of the polysubstance use issues. So the intention as part of the funding they will receive will be to assist the jails in developing protocols, as well as educating and providing technical assistance to the medical staff as to how to treat individuals who may have a polysubstance use disorder, but also, what are some of the protocols? Not every jail is as far along as Camden County, who's one of the flagships here in New Jersey, for sure. The warden at Camden has just been a true leader in that. So it's our hope that over the course of the next year, those centers of excellence will make contact with all the jails and begin to work with the medical staff around developing protocols and develop additional expertise for those those particular medical providers to be able to address this.
Thank you. So we have a question asking about how you all got started with developing your policies and procedures for MAT, MOUD in the jails. And they'd like to know, did you start totally from scratch, or is there a resource online that might provide a basic framework? And they're asking from the perspective of being an organization or a group that wants to get started with developing their own policies and procedures.
So how we started, I mean, funding, the availability of funding from the state certainly helped convince some of our leaders and partners here locally to be able to venture into providing this treatment in the program. And some of our policies were developed from the ground up. Others, I mean, we did rely on some of our partners. We put the word out to any jails that were maybe already providing this. I know Albany, New York was certainly a destination that we had reached out to. We also applied for a technical assistance grant that through BJA to help inform best practices around MAT. And because we started with Vivitrol first and then added in the next two, there's the additional forms of medication to follow. With that comes pros and cons, because we develop a program that's specific to Vivitrol and administering Vivitrol, and then you add buprenorphine and methadone, and everything's different. And so that's why for us, the importance of having our biweekly case conferences have really been fundamental and sort of been the foundation for our program, so that we always have a touch point to talk about what's working, what's not working, and is it as we envisioned. But we certainly relied on the community and our colleagues across the country to see what's already there. So some we started from scratch, some we begged, borrowed and asked to use.
Thank you. And a follow-up question about that is intake forms. Does anyone on the panel have recommendations of where an agency that's just getting started with some of this can look for some like sample intake forms or other resources for developing intake forms to determine eligibility for medications?
So we don't use an intake form per se, and I think this is where it's really having the conversation about how is this embedded into the practice of your jail and not viewed as something completely separate. For us, it's part of our intake process begins with asking a question of whether or not you self-report substance use. And if you self-report substance use, it leads to a series of questions. Before MAT, then it would result in identifying whether or not you're appropriate for detoxification withdrawal or for MAT. But we now we have a DAS-10, which helps to identify the severity of substance use. And then depending upon where you score, it triggers an ASI, an addiction severity. So it's not just this thing off to the side, like, okay, your substance use, maybe your MAT. It's very much embedded into our medical intake. And I think starting there versus feeling you need to have something separate, it should be really from the beginning with your medical team.
Right. Most New Jersey jails, and I think generally speaking, there's really 3 points where there's a screening for not only substance abuse, for mental health and other risks. So when an individual comes into the jail to get ready to be booked, there's an initial officer who's going to be just giving a look-see, see if anything behaviorally or otherwise dramatic is happening. Secondly, when the person gets booked, many jails have questions that if you looked at any of the screening instruments, including the jail mental health screen, which Policy Research Associates did, there are a lot of basic questions. And then finally, every individual coming in is going to be screened by a nurse. And very often that nursing intake has specific questions, again, that really mirror a lot of the mental health or substance abuse basic screening instruments, to identify somebody who potentially could be suffering from withdrawal or something over time. And then I think, as Sharon said, the more detailed situations would then be followed up. When there was more time, if somebody really looked like they had mental health, substance abuse, there would be a referral to the medical service provider. Now it's a little tougher because that person's coming in and going out. But that's typically how each jail at least gets to the point of a basic, call it a screen, and then from there. Sharon, does that sound right to you, or Noah?
Yes.
Thank you. So Noah, this one's for you. A couple of questions about looking at long-term outcomes. What are you working on in terms of looking at what some of the long-term outcomes are of this project implementation, and how are you tracking that? Do you have any preliminary information you can share with the audience in the last couple minutes for today?
Yeah, it's a great question. So I think Camden's a great example of kind of data collection and tracking their own outcomes. And I think Sharon kind of showed some preliminary data, even though there wasn't a lot of time. We didn't continue looking at this specifically in New Jersey, and we're definitely continuing to collaborate, and it would be great to think about some more projects to look at these outcomes long term. I can say from kind of research in other parts of the country, there's a lot of interest in looking at outcomes from jail-based medication treatment. Just as an example, we're looking at a data linkage project in New York City right now, looking at outcomes of individuals who receive medications while in jail. And we do see significantly reduced overdose risk, as well as reduced acute care hospitalizations and other negative outcomes upon release. So I think the evidence, not only from the US, but many other countries, really points to how important these treatments are and really long-term outcomes. And I'm sure that this is similar to what we would find in New Jersey and other places that will implement this. So it's exciting to see that the implementation is really ramping up to actually be able to see a dent in these outcomes.
Right. We do track through the monthly contract monitoring reports, staying on an MOUD 3, 6, 9 months, etc. But that really depends on the jails as well as recidivism. So those numbers, in terms of the total numbers, tend to drop off over time. Didn't have time to show that today, but they're much smaller numbers. And it would require some kind of linkage with an OTP and a follow-up in terms of looking at the longer term outcomes, which of course can be costly, and it's something that we may look at in the future. I think our real thrust was to get this moving, get people on medications. We have real interest from our ATOD group, which is the it's the OTP Association, in collaborating with the jail. So we will have them at a warden's meeting hopefully soon. So we're doing a lot of collaborative things, and so hopefully.
Thank you. And we're just in the last couple of minutes. I want to squeeze in one last question, if I can, just get a brief answer about partnering with community corrections. What does that relationship look like? And I will say, I'll just say, I'll open that to anyone who would like to just maybe give like one or two parting sentences about how you're partnering with that stakeholder group.
Well, let me start. Sharon, go ahead.
Oh, no, go ahead.
No, we have a drug court, or now called recovery court, in every vicinage in the state. And so very often individuals coming out of the jails are going into recovery court. Our division provides the substance abuse treatment for those courts. So there's definitely a continuity there. And very often probation, if they're not in a recovery court, can access any of the substance abuse providers. That's online. We have a method for folks to call and get connected. So I think we're really trying to do that for a whole range of substance abuse treatment services.
Yeah, I mean, I would just, I guess sort of, yes, that's all of the things that are happening for probation, recovery court, also because of criminal justice reform, pretrial as well. And so they've been great partners for ours, and facilitating, especially for those that are in recovery court, that are going to an inpatient program. There's a lot of coordination to ensure that information shared with the inpatient program, the medication goes with them, and that we're making sure that the program will take them because they are receiving MAT. So they're one of our key partners at the table.
Thank you. Thank you so much. So I'd just like to take another opportunity to thank all of the presenters today, thank all of the audience members who participated. We tried to get to as many questions as we could. I know we couldn't get to everyone's questions. This event is recorded. Everyone who is registered for the event will receive a copy of the slides and a notification when the recording goes to the YouTube channel. You'll see in the chat, there's a couple of documents being shared. Just FYI, these will also be included in an email to all registrants. So if you missed the opportunity to download the publications, you can get those in the follow-up mailing as well. The one document we do not resend after the event is the certificate of attendance. It is not for CEU credits, but if you'd like to download a copy just for your own portfolio, that's also being placed in the chat right now, and we'll be posting that a couple more times before folks sign off. I've got a couple of closing slides just to cover briefly. So if we could just get to the next slide. Here are the resources for download. If you'd like to join our listserv, if you haven't already done that, here's the address where you can sign up to receive our notifications. We're also adding a closing poll. This is totally optional. If you'd like to give us feedback, please enter your comments here. We do share all of these data with SAMHSA and really appreciate any information you can share with us here. And finally, our contact information. If you'd like to contact the Gain Center or SAMHSA, here is the information where you can reach us. And with that, we will end today's event. We'll stay online a little bit longer for those of you who are still downloading the materials, but the speakers will be signing off now. And once again, thank you all for joining us today, and we hope you all have a great afternoon.
Thank you. Have a good day.
Thanks for your participation.
Thank you for having
Have
us.
a good one.